All right, today we're going to do something a little different. We're not just going to memorize drug dosages. We're going back to first principles to really understand the why behind some of the most common antivirals out there, like why one is perfectly safe for a fetus but can be really dangerous for a dehydrated kidney, and why sometimes timing is literally everything. So let's dive in. You know, what's the link between a young, healthy person suddenly going into acute kidney failure and a senior citizen ending up with a lifetime of debilitating nerve pain? Well, the answer is the same: the mismanagement of very common antivirals. And the thing is, both of these are totally preventable outcomes. Understanding why they happen is the key to making sure they don't happen. Okay, so how do we stop those bad outcomes? Well, we got to go back to basics. We have to start with the foundation. Let's talk about the whole family of drugs ending in cyclovir. You know, Acyclovir, Valacyclovir, and Pharmacology. They all work in this really elegant way, and once you get it, all the clinical decisions just click. So check this out. What's so cool here is how specific the attack is. The drug floats into one of our cells, but it does nothing. It's totally inactive. The real magic trick happens right here, in step 2, where an enzyme that only the virus has, called Thymidine Kinase, flips the on switch by adding a phosphate. Once it's activated, it's like a guided missile that goes straight for the virus's copy machine, its DNA polymerase, and just stops it cold.
And this right here, this is the whole game. It's a concept called selective toxicity. So why doesn't this drug just wreck our own healthy cells? It's because our human enzymes, well, they're just awful at flipping that on switch. They pretty much ignore the drug. And hey, this even explains how drug resistance happens, right? In patients who are immunocompromised, the virus can actually mutate that one enzyme, and poof, the drug is useless. This is why these drugs are so targeted, and usually so safe.
Okay, so that's how it works. Now let's take that principle and apply it where it really matters, in the clinic. We're going to look at two super common but very, very different situations.
So we've got a 7-year-old with chickenpox versus a 68-year-old with shingles. Now here's the kicker. It's the exact same virus, Varicella Zoster, causing both problems. But how we treat them, completely different worlds. Let's start with the older patient. All right, so you've got this 68-year-old patient. They've got that classic, painful, blistering rash of shingles. What is the single most critical thing you need to be thinking about? And I'll give you a hint, it's not the dose, and it's not even which specific drug you pick. It's all about the clock. You have exactly 72 hours from when that rash first shows up. That's it. That's your one and only chance to prevent something called post-herpetic neuralgia. That's a miserable, chronic nerve pain that can literally plague a person for the rest of their life. You miss that window, and the benefit of the treatment just drops off a cliff. Okay, so we know we have to act fast, but which drug is best? Look, standard Acyclovir. It works, but its bioavailability is just terrible. That means a patient has to pop a pill 5 times a day. Who's going to stick with that? But then you have a prodrug like Valacyclovir. Your body converts it into Acyclovir, and you get 3 to 5 times the drug level in your blood. That means you're only taking it 3 times a day. This isn't just about convenience. It's about making sure the patient actually takes the medicine, and that's exactly why Valacyclovir and Pharmacology get a grade A recommendation for shingles. All right, let's switch gears. Back to our 7-year-old with chickenpox. He's got that classic itchy rash, the parents are freaking out a little, and your first instinct is probably, I should treat this. But hold on. Should you really? You know, based on the best evidence we have, the answer is a hard no. For an otherwise healthy kid under 12, the grade A recommendation is not to use antivirals. Why? Because for most kids, it's a pretty mild, self-limiting thing. The benefit of the drug is tiny, like it might reduce their fever by about 1 day. That's it. Now, there are exceptions for sure. You do treat if the kid is over 12 or has certain chronic conditions. And please, this is a huge safety alert. Never, ever give a child with any viral illness aspirin. You're risking Reye syndrome, and that is a truly devastating condition. Okay, quick sidebar, but a really important one. What about pregnancy? A lot of people get nervous about this, but the data is actually really clear. Acyclovir and Valacyclovir are category B, and we have a lot of reassuring human data showing they're safe to use. In fact, for a mom with a history of genital herpes, we actually recommend starting suppressive therapy at 36 weeks. Why? To prevent an outbreak during delivery and protect that newborn. All right, let's switch gears completely and talk about a virus that's on everyone's mind, COVID-19. There's been so much information and misinformation flying around, so let's just cut through the noise and stick to what the actual evidence says right now. This really breaks it down into evidence versus myth. On the evidence side, you've got Remdesivir. The guidelines are pretty clear. It's for patients who are sick enough to be in the hospital and need oxygen. Now, it's not a silver bullet, but good studies show it can shorten recovery time by about 4 days. Then, on the other side, you have the myth. Look, despite all the hype, the big, well-done randomized controlled trials, the gold standard of evidence, showed 0 benefit for ivermectin. No improvement in mortality, no reduction in hospitalizations. That's why all the major health organizations have a grade A recommendation against using it for COVID-19.
So, if you are going to use Remdesivir, there are a few key things you absolutely have to know. First, it works differently. It goes after the virus's RNA polymerase, not DNA polymerase, like the herpes drugs. Second, it's a 5-day course. If the patient isn't improving by then, just stop it. Continuing is all risk, no benefit. And finally, this one's critical. Watch the kidneys. If a patient's eGFR is less than 30, it's a no-go. And interestingly, it's not because of the drug itself, but because the vehicle it's mixed in can build up to toxic levels.
Whew. Okay, we've gone through a lot. So let's boil it all down to 3 simple, non-negotiable rules. Seriously, think of this as your save your license summary. These are the things you can't afford to get wrong.
Rule number 1 is simple. Mind the kidneys. High-dose IV Acyclovir can literally form tiny crystals in the kidneys, and that can cause acute kidney injury. The good news is this is almost entirely preventable. You just have to make sure your patient is hydrated, and this is the big one, you have to adjust the dose based on their kidney function. Getting this wrong is considered a never event in medicine. It just shouldn't happen.
Rule number 2, beat the clock. Yeah, I'm repeating this because it is that important. When it comes to shingles, that 72-hour window is non-negotiable. If you're delayed treatment past that point, you are basically doubling your patient's risk of getting that chronic, awful nerve pain. The intervention is easy, but the timing is everything. Don't miss that window.
And that brings us to rule number 3. Watch the eyes. If you ever see a shingles rash on the tip of someone's nose or anywhere near their eye, I want you to stop everything. This is a true ophthalmologic emergency. It's called ocular zoster. It's a huge red flag that the virus is in the nerve that goes to the eye and they can cause blindness. This isn't a wait and see. This is a call ophthalmology right now situation.
Okay, so to tie this all together, I want to leave you with one last way to think about this. Think of treating shingles with antivirals like using a sprinkler system during a fire. If you hit the button and turn those sprinklers on within 72 hours, you put out the fire, you save the building. Minimal damage. But if you wait longer than that, the fire is already burned through the structure. The building is damaged. Sure, the rash will eventually go away, but that structural damage, the neuralgia, that chronic pain, is already baked in. And that's what we're trying to prevent.